Hi. So, in my last lecture, I had spoken about approach to stridor in children, all congenital causes. And now, in this lecture, I'll be speaking about all non congenital causes of stridor in children. So, the non congenital causes of stridor in children are infections, acute laryngotracheobronchitis, croup, epiglottitis, tracheitis, retropharyngeal abscess, diphtheria, laryngeal papilloma, and others are laryngeal trauma, anaphylaxis, foreign body aspiration, caustic burns, and vocal cord dysfunctions. Now, what let's discuss about very important causes of stridor in children, that is upper airway infections. So, if the infection is of adenoids, it's adenoiditis, tonsils, it is tonsillitis, then epiglottitis, then anything below the glottis is all the lesions in the subglottic areas of infections like croup, etc. And then in the tracheitis, if the lesion is in, if the infection is in extrathoracic trachea. So this is the supraglottic region, and the upper airway infections in the supraglottic region are the peritonsillar abscess, retropharyngeal abscess, epiglottitis, diphtheria, and foreign body aspirations. Then the symptoms typically are drooling of saliva, soft stridor, and the child typically looks ill because they are all bacterial infections. This is the infraglottic region, and the lesions are LTB, that is laryngotracheobronchitis or croup, bacterial tracheitis, foreign body aspirations, and diphtheria. So, if we leave aside foreign bodies can be found in children anywhere. So, rest of the causes are all infective. So, in my this lecture, except diphtheria, I will taking you through each kind of infections. So, in infraglottic region, the typical presenting symptom is barking cough and significant stridor. So, let's see one case. 1.5-year-old boy came with fever and increasing stridor for 3 days, and there is a history of upper respiratory tract infection 3 days back. So this is the stridor which is happening in inspiration, and so this is clearly a croup. Croup is a viral inflammation of larynx, trachea, and bronchi. It is usually caused by parainfluenza type 1, 2, and 3, but it may be caused by other viruses also. It occurs mainly in children 6 months to 3 years of age. After an upper respiratory tract infection, the child develops the characteristic barking cough, hoarseness, and inspiratory stridor, depending upon which part of the larynx and trachea is involved. Symptoms are worse at night, and they are aggravated by agitation and crying. The child prefers to sit up in the bed and held up upright. Now, what is the differential diagnosis of croup? So, the nearest and closest differential diagnosis are retropharyngeal abscess, bacterial tracheitis, and epiglottitis. So, the onset in croup is gradual, but in retropharyngeal abscess and bacterial tracheitis, also it is gradual, because there is a preceding upper respiratory tract infection followed by this bacterial infection. But in epiglottitis, it is a sudden onset. The child looks well in croup because it's a viral infection, but in rest of the three, the child looks sick, and he may look very sick in cases of epiglottitis and bacterial tracheitis because they are all bacterial infections. Fever may be low in croup, but it is high in rest of the three, in retropharyngeal abscess, bacterial tracheitis, and epiglottitis. The cough in croup is barking and loud. It's barking also in bacterial tracheitis, but in retropharyngeal abscess, it is because supraglottal lesion, the cough is minimal, and even in epiglottitis, the cough is minimal. The stridor is harsh in croup and it is variable in retropharyngeal abscess. It is harsh in bacterial tracheitis and it is soft in epiglottitis. The pointers are that in croup there is a prodrome of URI. It is worse at night. In retropharyngeal abscess, the pointer is pain on swallowing and the stiff neck and torticollis, which are typical triad of retropharyngeal abscess. In bacterial tracheitis, there may be a preceding history of viral infection and there is pain during swallowing. And in epiglottitis, there is drooling of saliva and the child takes up a sniffing position. X-ray, although you don't have to do X-ray in each of these cases, but X-ray, if done in croup, it shows a steeple sign, that is tapering of the subglottic space. In retropharyngeal abscess, we need to do if we do an X-ray chest, there will be widening of prevertebral space and there could be air fluid shadow. In bacterial tracheitis, we could see a narrowing of tracheal lumen and the tracheal lumen will be irregular, and there will be a thumb sign in epiglottitis because of the swollen thumb. Now, quickly about Wesley's Croup score. It has a score of 5 and it takes 5 parameters: stridor, retraction, air entry, cyanosis, and consciousness. So, if stridor is not present, the score is 0. If stridor is present with agitation, the score is 1. And if the stridor is present at rest, the score is 2. Retractions, if there are none, the score is 0. If they are minimal, then score is 1. If they are little more, score is 2. And when retractions are severe, then the score is 3. Air entry, if normal, the score is 0. If it is decreased very much, the score is 2. If there is no cyanosis, score is 0. But if cyanosis is there with agitation, the score straight away goes to 4. And if cyanosis is present at rest, the score goes to 5. Consciousness, if it is normal, the score is 0. But if it is altered, the score is 5. So if the score totals to 0 to 5, it is mild. If the score totals to 3 to 5, it is moderate. And severe is 6 to 11. And if the score is more than 12, there is impending respiratory failure. Now, quickly you can grade severity clinically also into mild, moderate, and severe by taking the parameters general appearance, stridor, respiratory distress, which are all observed, and just plugging onto the monitor, checking the pulse oximetry, saturation, oxygenation. So mild, if you can grade the group as mild if the child is happy, feeds well, and interacts with you and parents. If the stridor is there on coughing and crying but not at rest, and if there is no distress and oxygenation on room air is more than 92%, you can call it mild. You can call it moderate if the child is fussy and not comforted by the parents. Stridor is at rest and worsens with agitation. There is some distress and tachycardia, but the oxygenation still is more than 92% in room air. And you call it severe if the child is restless, agitated, altered sensorium, stridor is at rest, worsens severely with agitation, there's marked tachycardia and severe chest retractions, and saturation is less than 92% in room air, and when the child cries, there is cyanosis. So, in management, the mainstay of treatment in management of croup is to manage the airway by ABC. So, you have to take care of the ABC first. Most children can be managed safely at home. Moderate to severe croup will require admission. Oral steroids are beneficial even in mild croup. Oral or IM dexamethasone used as a single dose of 0.6 milligram per kg. Nowadays, it is recommended even less, like 0.3 milligram per kg. Or you can give nebulized budesonide 2 milligram nebulization every 12 hourly for 4 doses if there is persistent vomiting and the child cannot tolerate oral. Or you can also give oral prednisolone 2 milligram per kg for 3 days, which will be as effective as any of the above treatment. Nebulized epinephrine also is given in cases of moderate to severe croup, and the dose is 0.25 to 0.5 ml per kg of 1 is to 1000 epinephrine in 3 ml of normal saline, and it may be repeated every 20 minutes. The duration of action of activity of epinephrine is less than 2 hours, so observation is mandatory for at least 2 hours, otherwise there will be a rebound. You can discharge a child home after giving nebulized epinephrine if you've observed for 2 to 3 hours of period and there is no stridor at rest and normal pulse oximetry in room air and there is good air exchange. The color is normal and normal level of consciousness, and the child has demonstrated ability to tolerate fluids by mouth. But epinephrine should be given cautiously in patients with tachycardia and congenital heart disease. So, to summarize the management of croup, mild, moderate, and severe, hydration is a must for all three types of croup. Antipyretics you may need in all three types. Oxygen will be needed only in moderate to severe because you will be admitting them. Dexamethasone you can give in all three. Budesonide nebulized can be given in all three. There is no role of nebulized salbutamol, but nebulized epinephrine is given for moderate and severe croup. There is no role of antibiotics and no role of antacids. So to summarize, if the child has mild croup and feeding normally, no respiratory distress, no stridor at rest, so there is no need to investigate. Single dose of nebulized budesonide or oral steroid and send the child on home-based treatment. Ask the parents to keep the child hydrated and report SOS. If the child has moderate croup and child is fussy, moderate respiratory distress and stridor at rest which increases on agitation, then you have to admit the child, give humidified oxygen, steroids, IV fluids and observe. If there is improvement, decrease oxygen and re-establish feeding. Discharge when distress decreases and the child feeds well. But if there is deterioration, treat this child as severe croup. And how do you define severe? It's restlessness, severe distress, hypoxia, stridor at rest. So it is severe. Admit the child in PICU because this child may need intubation. Give oxygen, IV fluids, and nebulize adrenaline, steroids. May explain that the child may need ventilator, may need tracheostomy as a last resort also. So we've seen there is absolutely no role of antibiotics in treatment of croup because it's essentially a viral disease. Now, another important bacterial disease is epiglottitis, which we see less and less these days because of the H influenza B vaccination. So, it is the inflammation of the epiglottis. It is caused by most of the time infection, but caustic ingestion, thermal injury, and local trauma are also important non-infectious etiologies of epiglottitis, usually caused by H influenza B, but staph and streptopneumonia may also be responsible for epiglottitis. Children less than 5 years of age may present with sudden respiratory distress, anxiety, and a characteristic tripod or sniffing position because the child will need to keep his airway open like this. Diagnosis is made by characteristic sign and symptoms, and they are toxic appearance and distress, sudden onset of high fever, stridor, drooling, change in voice and muffled voice, hot potato voice, severe sore throat and dysphagia. The potential for rapid progression to complete airway obstruction because this epiglottitis has, so the threshold for suspicion should be very, very low. Airway management obviously takes the priority, and most of the time it is H influenza B, so amoxicillin would be the best choice of antibiotics. But if you have found that it is staph and streptopneumonia, then you can choose the antibiotic accordingly. Another child, 17-month-old child, female, history of cough and cold for 4 days, high fever for 2 days, drooling and refusal to feed for 1 day. The child lies on one side and has a soft stridor. There is a soft swelling of the neck, and the child prefers to keep his neck flexed. So we see this is the kind of a stridor or the noisy breathing we hear. So the diagnosis is retropharyngeal abscess. So retropharyngeal abscess can be diagnosed on CT. So we did the CT neck, and there is we can see a shadow which is abscess which is behind the pharyngeal wall, and sometimes you may see air fluid levels also. So CT is the only diagnostic modality to find out retropharyngeal abscess. So the retropharyngeal space contains two chains of lymph nodes, and these lymph nodes drain into the nasopharynx. These drain the nasopharynx, adenoids, posterior and paranasal sinuses, middle ear and eustachian tube. All from all these areas, they drain to retropharyngeal space lymph nodes. An infection in any of these areas may lead to suppurative adenitis of the retropharyngeal lymph nodes. The kid appears very sick, and there are characteristic signs like dysphagia or dinophagia, drooling, neck stiffness, and you could also see a neck mass. For management, of course, for all these things, airway management takes the priority because this child can go into acute respiratory arrest very soon. It is usually caused by Streptococcus pyogenes, Staphylococcus aureus, and the anaerobes present in the oral cavity. Antibiotics may be sufficient if the abscess is less than 2.5 centimeters square, but if it is more than 2.5 centimeters square, generally a surgical drainage plus antibiotics are needed. So cover for, because we know it is caused by anaerobes also, so cover for gram positive and the anaerobic bacteria both. So a 5-year-old child came with high fever for 3 days, followed by severe stridor, barking cough, and impending respiratory failure. We did the bronchoscopy, and as soon as we put in the bronchoscope, we find pus coming out of the glottic opening, and this is at the subglottic space. And see, the trachea is full of pus. We know tracheal lumen is visible. This is completely obstructed trachea by pus. So this is acute bacterial tracheitis. The predominant clinical features of bacterial tracheitis are airway obstruction, stridor, cough, and respiratory distress. It is caused by Staphylococcus aureus, Streptopneumonia, Streptococcus pyogenes, alpha hemolytic streptococci, and Moraxella catarrhalis. The typical process is that there is a viral infection, and viral infection of the upper airway and lower airway leads to altered immune response, which will welcome all the bacterial infections. There will be mucopurulent exudates and ulceration and sloughing of mucosa, and which will cause airway obstruction and the symptoms of airway obstruction with which the child presents. The diagnostic criteria are upper airway obstruction and any two of the following: evidence of intratracheal membranes or mucopurulent secretions or laryngotracheal inflammation on direct visualization or positive bacterial culture. And if we do a lateral x-ray, we'll see the tracheal lumen narrowing and irregularity of the lumen. Of course, there should be a high index of suspicion. You can diagnose it only by flexible bronchoscopy and cultures. And again, in management, airway management takes the priority, and parenteral antibiotics may be given for a long time, ceftriaxone plus clindamycin or vancomycin or cloxacillin to treat the staphylococcal infection. So these were the bacterial causes. Now, 3-year-old female, history of corrosive ingestion 15 days ago, came with severe stridor and respiratory distress. So we did the bronchoscopy, and we found that there is a stenosis of pharyngoarytenoid folds. Pharyngeal and laryngeal inlets are common. So this is because of the corrosive burn. Now this was a 14-month-old child. He came with stridor. यहाँ से फिर एक कहीं और ले गए. So there was no, we got the X-ray done, and here we see a button battery lying at the cricopharynx, and the mother had absolutely no idea that the child had swallowed the button battery. So we did the bronchoscopy. The after the removal of the button, we did the stridor still persisted, and what we see on bronchoscopy is that there is swelling of the aryepiglottic fold and there is partial vocal cord palsy. Now, this was a 9-month-old child who came with severe stridor, and just imagine what had happened. This child had an upper respiratory tract infection and wheezing, for which parents gave the child steam inhalation, and this child got burnt, and this was a deep burn causing see the all faces burnt and inside of the mouth was burnt, and this child came with stridor. We needed to do a tracheostomy in this child. So this was a laryngeal trauma leading to stridor. A 5-month-old child came with severe respiratory distress and impending respiratory failure. This child had severe stridor and was getting cynos. We thought of doing a bronchoscopic intubation, and as soon as we put in the bronchoscope, we saw something jutting out of the glottis. So this was a foreign body, and see such a huge foreign body. It was a peanut peel that was shoved inside the mouth of this 5-month-old baby by the elder sister who was eating peanuts. So this was a foreign body, and foreign bodies can be found anywhere, and especially so in India. It is always unreported. Parents will never give a history, but you always have to suspect a foreign body. A 5-year-old child with stridor and severe respiratory distress with impending respiratory failure came to us, and he gave a history of severe respiratory distress earlier also. We got the MRI done, and we can see something just above the glottic area bulging out. We did the bronchoscopy and we find this cauliflower like structure, which is extensive papillomatosis. So, the laryngeal papillomatosis are the infection by human papilloma virus type 6 and 11. There is a high risk of triad of teenaged priming gravida mother, vaginal delivery, and the firstborn children. The usual point of clinical manifestation is 3 to 4 years of age. Papillomas can grow quite large and obstruct the laryngeal opening completely, as they did in this child, and they may extend up to the lower airway. The diagnosis is cauliflower like appearance of growth, usually above the vocal cords, and signs and symptoms are progressive dyspnea and hoarseness and stridor. The treatment is resection of the papillomas either surgically or with microdebrider or laser, and virostatic drug cidofovir may be given, but it is very, very expensive. Now, word about inducible laryngeal obstruction. If there is an inappropriate transient reversible narrowing of larynx in response to external trigger, this typically presents with recurrent acute episodes of dyspnea and stridor. It may be misdiagnosed as asthma or occur concurrently with asthma. This stridor is more pronounced with exercise and resolves during sleep. This disorder may be benign at any age, begin at any age, but most commonly it presents during adolescence. During the symptoms of episode of inducible laryngeal obstruction, paradoxical vocal fold adduction can be seen during inspiration. So we can see that during inspiration, the child, their vocal cords are in an abducted position, but in inducible laryngeal obstruction, there is adduction of the vocal cords, hence the typical stridor. The inducers of triggers of ILO, that is inducible laryngeal obstruction, can be isolated or it can be they can be multifactorial. The most common inducers are exercise, irritants, emotional stress, idiopathic, and or sometimes no specific inciting agent can be clearly identified. Flexible laryngoscopy is essential to the diagnosis of inducible laryngeal obstruction, and the treatment is behavioral modification and speech therapy. Anaphylaxis is an important cause of acute onset stridor. It may be severe and life threatening. The signs and symptoms are respiratory. In an infant, you have to be very careful in diagnosing anaphylaxis, because you may not find all the signs and symptoms and history. So there will be respiratory distress, change in voice quality, choking, stridor, wheezing, drooling, or cough. There may be skin symptoms like hive, itching, or mouth swelling, which may be absent in an infant, and or gastrointestinal symptoms like nausea, vomiting, diarrhea, and abdominal pain. The management again is take care of ABC. IM adrenaline 0.01 milligram per kg, fluid support, H1 antagonist, beta 2A antagonist, inhalation, and intravenous corticosteroids. So to again take home message is infections are important cause of stridor in children, and there are major differences in the airway of infant and adults, and one must keep them in mind while managing stridor of a child. And children may go into respiratory failure faster than adults because of these inherent differences, because the airway is very small and the resistance increases to the power of 4 with slightest decrease in the lumen diameter. And presence of stridor suggests that there is an obstruction at the level of oropharynx, larynx, or extrathoracic trachea, so it has to be taken care of immediately. History gives a clue that there could be infection, and all these infections are to be treated at priority with the antibiotics or with adrenaline or steroids, as and whatever the history suggests. And it is a priority to find out the cause and manage the thing properly. Thank you.